We're going to continue with pharmacology, looking at calcium channel blockers. And we're going to discuss the mechanism. That's how these medication works. They disrupt the movement of calcium through channels. And they block the L-type voltage-gated calcium channel. So they block the calcium channel. Okay? And as a result, they cause vasodilatation. The blood vessel dilates. And that is why we use them quite a bit to treat hypertension because they cause vasodilatation. Some of the calcium channel blockers, not all, reduce the force of contraction of the heart as well and can decrease the heart rate, but not all the calcium channel blockers do that. Okay. The one that does not do it is amlodipine. So, and we'll discuss this further, but amlodipine does not reduce the force of contraction of the heart, and it does not decrease the heart rate. Also, nifedipine doesn't do that. The calcium channel blockers that reduce the contraction of the heart and decrease heart rate are cardizem or diltiazem and verapamil. Right, so what are some of the medical uses for calcium channel blockers? Because as we say, they block the L-type calcium channels and cause vasodilatation. They're very good to treat hypertension. Okay, angina pectoris. We used to promote that. We really don't anymore. So I probably wouldn't say we use calcium channel blockers to treat angina. However, the calcium channel blockers that decrease heart rate, your verapamil, your diltiazem, we use those medications in atrial fibrillation and atrial flutter because they decrease the heart rate. Okay, so in addition to hypertension, we can use our calcium channel blockers to treat atrial fibrillation and atrial flutter. And as I alluded to before, there are two classes of these medications. All right, one we call the dihydropyridine type, and the other one the non-dihydropyridine. Okay, so the dihydropyridine type of calcium channel blocker, it reduces systemic vascular resistance. When we say that, it causes vasodilatation. It dilates the blood vessels and reduce arterial pressure as expected. And then the non-dihydropyridine, they have this phenyl alkylamine, which reduce myocardial oxygen demand and reverse coronary vasospasm. So we actually use calcium channel blockers if the patient has coronary spasm. So coronary spasm is a condition where the blood vessel around the heart, the coronary arteries, they can constrict, they can go into spasm, and that can give you chest pain, and to the extreme, you can get a heart attack. So we use calcium channel blockers for that. Okay, and then you have the benzodiazepine type, which have both cardiac depressant and vasodilator properties. So the only thing you need to know is two classes: the dihydropyridine and the non-dihydropyridine. What are some of the adverse effects? Because especially for exams, they just want you to know that we use these medicines to treat hypertension, atrial fibrillation, but they always come to the side effects because some of these side effects are very classic and they're medication specific. So if you can learn the side effects, it's good. Calcium channel blockers as a group, They can cause headache, redness in the face, angioedema. So angioedema is a big one. Okay, so your almost any of your calcium channel blockers can cause angioedema. So it's not uncommon to, patients with hypertension comes in and you put them on, say, amlodipine, diltiazem, nifedipine, anyone, and they come back a month or two later and the ankles are very swollen. So instead of running around the place trying to, find out what's going on, using diuretics and stuff like that, you just stop the calcium channel blocker or reduce the dose, and then the ankle swelling will goes away. Okay. Um, Gingival overgrowth or gingival hyperplasia, uh, probably more with nifedipine. So the gum can become real thickened with some of these medicines. They're probably more commonly nifedipine. And of course, the diltiazem, which is cardizem, and the verapamil uh, can slow the heart rate. Okay, can slow the heart rate. So be careful. Your nifedipine sometimes can increase the heart rate. But the thing to remember, if I'm just going to remember one adverse effect, angioedema, because if they're going to give you one of the problems with calcium channel blockers, almost straight across the two groups will give you angioedema swelling. All right. So these are the dihydropyridine type of calcium channel blockers. These the dihydropyridine types, they do not slow the heart rate and they do not decrease contractility of the heart. Okay, so you cannot use the dihydropyridine type to treat atrial fibrillation, atrial flutter. Okay, very common medication in this group is the amlodipine or the Norvasc. Okay, the felodipine or Plendil. Okay, and then your nifedipine or Procardia or Adalat. So these are the three most used dihydropyridine calcium channel blockers. Again, these uh, calcium channel blockers, they do not decrease the heart rate. They do not decrease the contractility of the heart, the dihydropyridine, as opposed to your non-dihydropyridine type of calcium channel blockers, which include your verapamil, also known as Kalan, Isopten, and then your diltiazem, cardizem, which we use extensively. Okay, so these medications would slow the heart rate and decrease the contractility of the heart. So if a patient have heart failure with reduced ejection fraction 20%, 30%, you really don't want to use any of these medicines because it's going to further reduce the contractility of the heart. And again, if the patient has a heart rate in the 40s, you don't want to use any of these medicines because it can further lower the heart rate. Okay, so the non-dihydropyridine reduces the contractility of the heart and reduces the heart rate as well. Verapamil, diltiazem. All right, so we'll move on now to digoxin. Very common medicine. You're going to see a lot of patients coming to the echo lab on digoxin. But how does digoxin work? What's the mechanism of action? So digoxin binds sodium potassium ATPase pump. So this is a pump inside the cells which maintains the electrolyte composition of the inside and the outside of the cell. Okay, so it's called the sodium potassium pump. So we know that sodium usually resides inside the cell, and potassium usually resides outside of the cell. So what this pump does, it maintains that neutrality. So digoxin inhibits this, it binds to this pump, sodium potassium ATPase pump, and decreases its function. And as a result, then because it binds the pump and it inhibits the pump, it increases the level of sodium ions inside the cells because it's constant. It's supposed to maintain the neutrality. So if you disrupt the function of the pump, the sodium inside the cells uh, increases, and that result in a rise in the level of the intracellular calcium. The thing about calcium, when calcium builds up into the myocytes, that the muscle cells, it increases contractility. Okay, so the net effect of inhibiting the sodium potassium ATPase pump is to increase the intracellular calcium, and because of that, the muscle contracts more vigorous. So we use digoxin in patients with heart failure, ejection fraction pretty low, or if the patient has atrial fibrillation, because by inhibiting the sodium potassium ATPase pump, it also inhibits it reduces the heart rate. It blocks the AV node. So it blocks the function of the AV node. So it it can reduce the amount of impulse coming from the atrium going to the ventricle. So that's why it's fairly good to use in patients with atrial fibrillation or atrial flutter because it blocks the AV node. Okay, remember where the AV node is? It's right at the junction between the atrium and the ventricle. So impulse coming from the atrium usually slows in the AV node and then goes on into the ventricle. If you use digoxin, it blocks that transmission from the atrium to the ventricle. So it's effective in atrial fibrillation. So if you remember your action potential, it lengthens phase 4 and phase 0 of the cardiac action potential. It's going to decrease the heart rate and increase contractility. Remember, we said because you get the buildup of calcium inside the muscle, the heart muscle cells, the myocytes, it increases the contractility and it decreases the heart rate by blocking the AV node. So what are some of the medical uses for digoxin? Patients with congestive heart failure with reduced ejection fraction, because we said that it increased contractility, so it's fairly good for that. Atrial fibrillation, atrial flutter, because it blocks the AV node and prevents and decrease the amount of impulse going into the ventricle from the atrium. So again, they want you to know, if you're doing an exam, they want you to know the adverse effects of digoxin. So especially if the patient is toxic, because digoxin has a very narrow therapeutic index. And what we mean by that, the dose to produce clinical response and the dose to get toxic are very close, very close. So it has a very narrow therapeutic index. So, you know, and medications like that it can be dangerous because 1 minute you're okay and the next minute you're toxic. So it has a very narrow therapeutic index. That is, the dose for clinical effectiveness is very close to the dose for toxicity. But one of the things when you're digoxin toxic, and a lot of time, you know, by how the patient presents, you can clinically diagnose digoxin toxicity. Little old lady, all of a sudden lose her appetite, nausea, vomiting. She tell you she have this halo around her eyes. She have abdominal pain. She lost weight over the last few weeks. You don't need to know that she's on digoxin, that digoxin toxicity. And we've seen it very, very, frequent in these older patients. So other things you can get is blurred vision, this yellow-green halo, very common. You can get with profound toxicity, you can get confusion because it's usually older patients, confusion, dizziness, insomnia. And then if you see a patient who have atrial tachycardia with AV block, I mean, 20 years ago, that's digoxin toxicity until proven otherwise. Patient have atrial tachycardia with AV block. I mean, that's was so classic, very classic. But almost pathognomonic of digoxin toxicity is something we call biventricular tachycardia. So you can get ventricular tachycardia by Gemini, but if you see biventricular tachycardia, it is almost always digoxin toxicity. There's another condition that can give you biventricular tachycardia. I think it's catecholamine induced um, uh, tachycardia, um, but digoxin toxicity. So okay, so that's digoxin. I mean, should have an idea, a little understanding of digoxin. What about nitroglycerin? Use it quite extensively in cardiology as well. There are different formulation of nitroglycerin. We have the nitro patch, you can put it on, or the nitro paste, the sublingual nitroglycerin you can put under your tongue. We can give you long-acting oral nitroglycerin, isosorbide mononitrate, isosorbide dinitrate, and we have the intravenous formulation. Okay, so nitroglycerin causes a vasodilatation, both in the arterial tree and the venous tree. Okay, so this is a very, very good medicine. If someone comes in with acute heart failure, you can almost use intravenous nitroglycerin solely to treat them. You know, you have to know how to use it. But anyway, so it's a very good medicine, but it causes arterial and venous dilatation. So it decreases the systemic vascular resistance. So patient comes in a heart failure, blood pressure 240 over 120. It's not a bad medication to reach for. Okay. It also dilates the blood vessel on the surface of the heart, it's the large epicardial coronaries. Uh, so that's one of the things it does. Okay, so it forms nitric oxide, which so how it works? The nitroglycerin forms nitric oxide, which activates guanylate cyclase and results in increased level of cyclic GMP in the smooth muscle. So that's how it works. That's a mechanism. Um, they're not going to ask you that, but if you can remember that, that's fine. Okay. What are the medical uses for nitroglycerin? So angina pectoris, so patients having chest pains because of a heart attack or because of blockage of the blood vessel around the heart. One of the first medication the patients reach for or be in the emergency room and is a sublingual nitroglycerin. So sublingual nitroglycerin. Um, we also can use it to treat hypertension. That patient who comes into the emergency room with a blood pressure of 240 over 120 in heart failure is probably one of the best medications to reach for, intravenous nitroglycerin. Um, it can be used for chronic heart failure. We really don't use it that much for chronic heart failure, but patients continue to have angina pain. You can put them on long-acting oral nitroglycerin. So the side effects of nitroglycerin, which again, as mentioned before, some of these medications are very classic side effects. So headache. Okay, people will tell you when I take my sublingual nitroglycerin, I get this splitting headache, or I went to the hospital and they put up intravenous nitroglycerin and I had this very severe headache. So a lot of the nitroglycerin formulation usually give rise to a headache. You can get vertigo, weakness, palpitation, nausea, vomiting, pallid diaphoresis, collapse. But commonly, so this is something medical people need to be aware of. Patients get chest pain, angina, and they take one sublingual nitroglycerin and they pass out. Remember what we said? It's a very potent vasodilator, not only the arterial but the venous. So some of these patients will have borderline blood pressure, 100/50. They have the chest pain, then they take the sublingual nitroglycerin. Sublingual goes to the bloodstream very, very quick. So you get a profound vasodilatation from it. Blood pressure falls even further, and the patient pass out. Very, 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 very common. Very common. So, yeah. So again, the different types of nitroglycerin, sublingual put under your tongue, the long-acting forms, isosorbide mononitrate, isosorbide dinitrate. These are the long-acting nitrates. The mononitrate is longer acting than the dinitrate, and of course the intravenous nitroglycerin. So this is something we use quite extensively in the intensive care unit. Again, especially patients who are hypertensive and if they're in heart failure, it's a very good medication to reach for. So we're going to discuss antiarrhythmics now. So remember, arrhythmia is an abnormal rhythm, okay? And when we did ECG, EKG, went over a number of abnormal rhythms. So we have medication to suppress these abnormal rhythms. Okay, we call these medications antiarrhythmic agents. So the mechanism of action. So we have antiarrhythmic agent to suppress atrial fibrillation, suppress atrial flutter, ventricular tachycardia, and ventricular fibrillation. So we have medication to suppress these abnormal rhythm because these are probably some of the most dangerous arrhythmias. And we have them, they're divided into class. So we have them in a class, and it's a Singh-Vaughan William classification. And it goes from a class 1 to class 5. Okay, the class 1 agents they interfere with the sodium channel. We call them sodium channel blockers. The class 2 agents we call these are really the beta blockers. So the class 2 agents are the anti-sympathetic nervous system agents, essentially beta blockers. Class 3 is potassium blockers. It blocks the potassium channel. Class 4 agents are your calcium channel blockers and other AV node drugs. And class 5 is mixed basket, unknown mechanism. So the Singh-Vaughan William classification. So it goes from class 1 through class 5. Again, class 1 is your sodium, 2 beta blocker, 3 potassium channel blockers, 4 calcium, 5 unknown. This is a very busy slide. So anyway, your class 1A, which is your sodium channel blockers, includes quinidine, procainamide, disopyramide. We don't use a lot of these medicines anymore. They're very effective, but they kill a lot of patients as well. So very effective, but very deadly. All right. So a lot of patients die on these medicines. So we're not going to go over them. We don't use them much anymore. Your class 1B, which is still sodium channel blockers, includes lidocaine. This is IV lidocaine, IV phenytoin, mexiletine, tokenamide. For the same reasons, we used to use a lot of IV lidocaine when patients had a heart attack and they come to the emergency, sorry, they ship up to the intensive care unit. We use lidocaine to prevent ventricular tachycardia, but the lidocaine was also killing the patient. So um, we rarely use it unless the patient have profound, ventricular tachycardia, which is probably not responsive to anything else. Um, the class 1C, which is again your sodium channel blockers, we use flecainide and we use propafenone. So these are the two that we use in this class, your 1C, flecainide, and your propafenone. Okay. Um, and then we said the class 2 is your beta blockers. So you have a whole string of beta blockers. Your propranolol, esmolol, timolol, metoprolol, atenolol. So all of these are your beta blockers. And we use them as antiarrhythmic because, again, remember we said they can reduce especially patients have atrial fibrillation, atrial flutter, it can reduce the heart rate. Your class 3 now, we use a lot of these. Class 3 amiodarone is one of the class 3, which is a potassium blocker. Amiodarone, we use sotalol, dofetilide. So, and we use dronedarone. So we use a lot of these. Okay, amiodarone is probably the most effective in all of these. Um, well, it's not the most effective, but it's very, very effective. For me personally, dofetilide is the most effective antiarrhythmic. However, it's probably the most deadly. Okay. So what we usually do, because since it's so good, but it can kill you, what we do, we usually start these medications in the hospital. So you cannot start dofetilide on someone as an outpatient. Patient have to be in the hospital, and you keep them in the hospital for 3 days and observe how they do on the medicine. I've had patients that the first dose I give them, they went into ventricular fibrillation, and if we didn't shock them, they would have died. So it's one of those medicines. Very, very good. If you can get a patient, especially atrial fibrillation, and sometimes nothing works but your dofetilide, okay? I mean, so you have to put the patient in the hospital. And once they tolerate it, it's usually very, very, very effective. So I would say number one, especially for atrial fib, would be dofetilide, and then your amiodarone would be next. But amiodarone usually don't cause a lot of arrhythmia. Amiodarone doesn't cause a lot of arrhythmias. I mean, the others uh, can and will, your sotalol, and of course the dofetilide. As a matter of fact, in the United States, dofetilide, a regular physician cannot prescribe dofetilide. So it has to be a cardiologist who have gone through um, some additional training, know how to use it. So, you can, as a physician, you can't just write a prescription and the patient, no, the different pharmacy have a list of who can prescribe the medicine, because I said this is deadly, you know. So you have to know how to use it. Dofetilide, Tickerson, the other name is Tickerson. So that is your class 3. And then your class 4, which is the calcium channel blockers. And the ones that we're talking about is your verapamil and diltiazem. And then your class 5 includes your adenosine, your digoxin, magnesium, and all that. Okay. Some of these medicines we use more than others. 30 years ago, everybody was on quinidine, procainamide, and disopyramide. And these patients were dropping dead, and they probably didn't know what was killing the patient. But, procainamide, I mean, quinidine, it's a deadly medicine. But, 30 years ago, we didn't have much options. So, um, okay. All right, so that's your antiarrhythmic. So we're going to stop here. and the next time we will discuss the others. But again, having a basic understanding of some of these medicines is important, if not only for the exams. You know, they want you to to have a sort of a global uh, cardiovascular knowledge, a little bit of everything, because you're going to have patient coming into the lab, you know, in varying state of health. Okay. So, all right. So good night.